All right, so um, let me introduce myself. Oh, you already gave me an excellent introduction. Chris Tran, you can just call me Chris. I live in Houston. My practice is in Webster, which is like a southeast suburb of Houston. I don't have any financial disclosures, and a little bit about my practice. So board certified ENT, special interests in airway optimization for sleep apnea treatment and just breathing in general. Love sinonasal surgery, functional frenuloplasty, and tethered oral tissues management. I do a lot of office-based techniques and procedures. I treat patients of all ages, pediatric and adult patients, and I try to really espouse a collaborative care model. So that'll be part of our discussion today. Objectives. So we're going to just explore the concept of collaborative care as it relates to the treatment of sleep disorders and airway optimization. And specifically from an ENT perspective, I know that there's a lot of stigma out there about ENTs not really participating in these collaborative care models. So hopefully this presentation can kind of get a little bit of an ENT perspective, both kind of showcase like my protocols and how I do it, but also like to help everybody kind of understand like why ENTs have that kind of reputation, and maybe some things to kind of help us to engage more ENTs so that they can be more part of the care team. Hopefully we'll be able to obtain some clarity on these objectives here. So, so when you talk about sleep medicine, it's very fragmented, right? So everybody kind of has their pathway, and unless you're working together, it's kind of these traditional kind of rigid pathways, right? So sleep medicine, you get a sleep study, you get a positive airway pressure device. I mean, some of this stuff is really like stereotyped, right? But that's the whole point, because a lot of the traditional, like people who are traditionally trained, it's really is, that's, you know, that's the basis of the stereotype, right? So dentists, you know, orthodontics, oral appliances, oral surgeons, you know, orthognathic surgery, ENTs, a lot of soft tissue surgery in the upper air digestive tract. But generally, you know, patients will tend to just seek treatment for all their different sleep-related symptoms from wherever they're going to go. Primary cares, you know, they may have some nasal issues, so they go to ENT. But when a lot of patients just kind of shop around and seek different treatments in a disjointed fashion, they kind of have to make the decision ultimately of which way to go in their treatment. And a lot of times there's not communication between providers that we can really kind of integrate the treatment and make it kind of flow seamlessly. So who sits at the table, right? When we talk about sleep and airway optimization, the concept that we need to go from is, you know, we need to move from a standalone provider model to a collaborative care model, right? So now, even though this presentation is kind of mainly focused on the ENT perspective, we definitely can't forget that there are many who potentially contribute to the team approach. In fact, there's probably everyone else but ENT in the audience right now, probably. Maybe there might be some other ENTs out there, but there are a lot of people in the team that can contribute. So just a kind of smattering of collaborators, right? So all walks of life and all specialties, subspecialties. We have to firstly make sure we involve the patient and their families, right? They have to be willing to participate. They have to support the patient in their goals to improve their sleep and airway. We have to get the pediatricians and the PCPs on board, right? Because that's really who's going to reliably see patients and be able to screen them for problems. So we do have to reach out and try to educate them and include them in the care team. Sleep medicine professionals, physicians, dental professionals, ENTs, a lot of acronyms and everything here. So I probably missed some too. Pretty much anybody who can help a patient, and it doesn't even have to be directly sleep related, right? So even, like psychiatry, right? Like, sometimes you need that, right? To be part of the care team. So yeah, we want to include everyone that should be included for each patient to collaborate. So in doing that, we achieve a team approach. So patients should be surrounded by any discipline that they need or that they just want, right? That's what we need to do. A tailored multidisciplinary plan, right? Okay, so as far as from a ENT perspective, typically whenever patients get sent to ENT, these are the things that people want, right? Evaluate and treat nasal obstruction, evaluate and treat nasopharyngeal, oropharyngeal obstruction, right? Tonsils and adenoids, right? Evaluate and treat laryngeal obstruction. Is there stridor? Is there laryngomalacia? So that's kind of like basic level participation, right? Like, people ask you to evaluate these things, you evaluate it and you treat it, and then you send them on their way, right? What we want to do is we want evolved participation, right? So collaborative participation. So even though it's really easy to do the basic technician level participation, right? You just evaluate the nasal obstruction. Do they have a septal deviation? You fix it, they breathe better through the nose, and you send them on their way, right? But is the patient really getting what they really need to be getting out of that interaction, right? Like, in reality, even though ENTs aren't really one of the core providers in typical airway care teams, they could be, right? Because look, a lot of the obstructions that happen for sleep apnea and things, a lot of that happens in the upper air digestive tract. Like, that's where we live, right? So really the best thing that an ENT can do is evaluate comprehensively the anatomy there. And that's how you can really participate well in the care team. Now, just evaluating the anatomy, not really enough, right? Like, you have to kind of know how everything fits in with the rest of the management and what everyone else is doing. So that's a big problem, right? Like, for ENTs that are not quote unquote evolved, right? So the myofunctional therapist will send a patient to you, and the patient needs to have a tongue tie release to help with the airway, and they send the patient to the typical ENT and say, okay, this patient has nasal obstruction, like, let's see if you can help us with that. So the ENT, looks at the nose and everything, and then they look at the treatment plan. Oh, like, this patient's getting a tongue tie release, like, that has nothing to do with airway, right? Well, why you got to be so close-minded, right? A lot of ENTs don't know. Like, that's just part of the problem with modern medical education, right? It's well, not modern, really, it's traditional medical education, right? So everybody is just taught what they're taught, right? So I think part of that being evolved and having a collaborative mindset is you kind of have to move away from that paternalistic, like I know everything, and be open to the fact that people may know some things that you don't, and are helping these patients in other ways that you don't quite understand. But it behooves you to, like, if you don't understand it, kind of look into it and see what it's about, right? So as far as talking specifically about like the ENT perspective, so I'll go a little bit into this. I don't want to go like too deep into like the science and everything. Maybe that's what you guys want, but you can let me know if that's what you want. But you know, from an ENT perspective, right? Like the nasal airway is king. Like that's our domain, right? So so I'll talk a little bit about like nasal airway, and then we'll kind of segue into other stuff. So generally, nasal airway obstruction, we talk about resistance to airflow, right? So you look at the Starling resistor model, right? So upstream resistance causes downstream negative intraluminal pressure. So if you have restriction in the nose, when you breathe, you're essentially like sucking against like a closed valve if the restriction is bad enough. So by sucking against a closed valve, you suck in the walls of the pharynx, which is distal or like downwind of the nose, and that causes collapse, right? Well, when that causes collapse, well, that's obstruction, but also it causes air bypass to whatever, you know, wherever the airflow has the least resistance is going to go. So you know, if you have that nasal blockage, you're going to get mouth breathing, right? You get mouth breathing, you know, open your mouth, tongue falls back, you get more blockage, you get more resistance, and it's a sick cycle, right? So also, when we talk about the problems with mouth breathing, you know, I think that's something that a lot of ENTs they use, right? Like you use that concept of mouth breathing to justify things like removing adenoids and things like that. But yeah, that's the interesting thing about tethered oral tissues, right? Is once you learn about it, it makes a lot of sense in how ENTs practice, but it's kind of like something that was there that you didn't know was there. So meaning like when you talk about mouth breathing, a lot of ENTs will think, okay, well, you have nasal blockage, and so that's why you're mouth breathing, right? You don't really think about the fact that the tongue's not up on the roof of the mouth blocking it as it should be, and it's just sitting down low, and that's another cause of mouth breathing, right? But it makes sense. The problem is we just haven't been taught that, right? And so, so when we talk about oral breathing, so how it affects central respiratory events. So when you mouth breathe, you tend to breathe more quickly. When you breathe more quickly, you eliminate more CO2 when you breathe it out, and then you get a decreased respiratory drive, right? And so that decreased respiratory drive, that's synonymous essentially with central apneas, right? So that's where blockages can also lead to central apneas, right? So and that's another problem too, right? Like ENTs see central apneas on sleep studies, and they're like, "Oh, central apneas is the brain." Okay, that's not my thing. You know, send to sleep medicine, right? So nasal ventilatory reflex. So airflow sensation in the nose stimulates respiration. So you actually like breathe faster and breathe more when you have that airflow sensation. That's why like empty nose syndrome is so bad, right? Like you feel like you're suffocating, you can't breathe because you don't have sensation in the nose. So these are all kind of factors that go into nasal airway obstruction that can influence the way that you treat patients with blockage, right? Very interesting study like studies in the like 80s and 90s where they actually like anesthetized the nasal cavity, and they essentially like did sleep studies, and they saw increase in obstructive apneas and central apneas. Interesting, right? Like no one will do that study now because nobody wants to get that, right? But similarly, right? So mouth breathing creates a reduction of this nasal ventilatory reflex, and so can have those similar effects. There's a lot like being studied about nasal nitric oxide. I don't need to really go really into it, but pulmonary vasodilator, increased oxygen uptake. So if you don't have the nitric oxide is made in the nose and in sinuses, right? So if you have poor nasal airflow, you get less nasal nitric oxide that's delivered to the lungs. You get less blood oxygenation, and you go down that pathway. So I don't know if that was too much science. So nasal valve collapse, right? So we talked about the nose being one of the highest points of airway resistance. So within the nose, the nasal valve, like the very front part that you can see kind of like this area here, that accounts for actually 2/3 of nasal resistance. So a large portion of the resistance to airflow in the nose can be found in this region, right? So, and that's why, this involves the nasal septum, that involves the turbinate, and also the nasal valve. So if you can modify this by a little bit, you can really increase nasal airflow, right? Now, if you kind of look at this picture and you look at this area, that's where like the mute device goes, right? Like the little stents that go in the nose, or breathe right strips. You can kind of pull that apart, right? So I include this a little bit because this is like an easy source of help that you can get from ENTs. There's a lot of newer technologies these days that you can do minimally invasive procedures to really help improve the nasal airflow. Not everybody's a candidate, right? But pretty much anyone who benefits from improving this area, like with a mute device or breathe right strips, is a candidate for some minimally invasive procedures that can actually modify that tissue. So just kind of spotlighting that technology. I don't have any like financial relationships with them, but it's such a good technology and it's so useful. And a lot of ENTs have access to this. So for anybody in the audience who has some patients that are undergoing anatomic improvements to their airway, but they have nasal blockage that is preventing them from doing proper myofunctional therapy, like you got to get those patients evaluated, right? And this is potentially something that, like, even for patients who are skittish and don't want to do surgery, this is like an in-office procedure, right? So you can, so this technology, you actually, you take this device and you apply radio frequency energy to different areas in the nasal valve, and you can actually remodel the tissues without actually even piercing the tissue, like without making any cuts. And so you can really change people's nasal breathing quickly, right? And sometimes that's a huge gain when you're doing all of these therapies, like expansion and things like that, that can take a long time. So sometimes you just want to like get some improvement, right? So I mean, just an interesting technology that's out there these days that essentially all ENTs have access to. So if anybody has any patients that are using, mute devices or like intranasal stents or breathe right strips, these are all good like potential candidates for this kind of thing. Invaluable for the minimally invasive toolbox. So anyway, oops. Okay. So a little data specifically for that that device. So the technology here, like the brand name is called Vivair, but look at the numbers here, right? Like 89% reported improved sleep quality, right? Now this is not like reduction in AHI, right? But this is just subjective improvement, right? Which is good. I mean, it's not reduction in AHI, but this is what patients want, right? So 94% improve ability to breathe through the nose during exercise or insertion, right? So that's when the air flows the most and you get collapse of the nasal valve. And, you know, they've done longitudinal studies, right? So you can see here that like long-term, you get maintained improvement. So that the nose score or nasal obstruction symptom score, when they start at around 80 and then they end up in the 20s to 30s, and it maintains that benefit over years, that's some pretty good long-term benefits. And it's minimally invasive. So like even if you had to repeat it, patients would easily do it again. I actually haven't had to redo anybody's, but that's technically an option. So anyway, so let's kind of go away a little bit from the nose. A lot of people, so another ENT centric procedure, so nasopharyngeal, oropharyngeal obstruction, tonsils and adenoids, right? So tonsillectomy, adenoidectomy, kind of bread and butter ENT cases. So easy kind of criteria. The American Academy of Otolaryngology actually has like clinical practice guidelines that talk about like these are like reasonable reasons to take out like tonsils and adenoids, right? So chronic tonsillitis. So this is like really old data, right? But people still use it. If you have 7 infections over the span of a year, or 5 infections over the span of 2 years, or 3 infections over the span of 3 years, it's considered chronic tonsillitis, and that's the Paradise criteria for, you know, being reasonable to remove tonsils. Sleep disorder breathing in kids, the practice guidelines actually talk about specifically these symptoms like growth retardation, poor school performance, bedwetting, and behavioral problems, which we all know are sleep disorder breathing symptoms. Also symptoms of tongue restrictions, but that's for later. So other factors, other things that can indicate that tonsils and adenoids should come out, antibiotic allergies or intolerances as you continue having to treat with recurrent antibiotics. PFAPA is a syndrome. It's periodic fever, aphthous stomatitis, pharyngitis, and adenitis, like lymphadenitis. So a lot of people, there's another similar syndrome as well, but people who commonly get, for example, like oral aphthous ulcers along with tonsillitis, pharyngitis. Those episodes tend to go away when you take out the tonsils. Peritonsillar abscess, so if the infection is bad enough to erupt out of the capsule and create an abscess, if you've had one before, you know it's terrible, and it can happen again more easily once you have it. So take those tonsils out. Adenoidectomy, there's a lot more, I think, controversy over it. I won't go too much into it specifically right now, but essentially for me, from ENT standpoint, if it's obstructive, that's a reason. If it's pediatric and there is a lot of sinus issues, oftentimes, so actually the primary treatment for chronic sinusitis is adenoidectomy in pediatrics, rather than actually manipulating the sinuses. So generally, right, ENT evaluation, what do you need from your ENT? evaluation and management of blockages in all of these regions of the upper airway tract, right? So you have to be able to evaluate from the nose, like anterior nose, to the nasopharynx, oropharynx, hypopharynx, larynx. Now, besides all of these anatomic options for improving the airway, what you really need from your ENT is true collaboration, right? So, you want them to be on the same page and not like diminish the other aspects of treatment, right? So that's really what you need. You need to have that collaboration team approach. So we kind of talked a little bit about how like ENTs don't really buy into a lot of this stuff, right? Like and especially like the big elephant in the room is the tethered oral tissues, right? Like ENTs don't like generally like buy into that, right? But as we've kind of, hopefully I've kind of showed a little bit, like when you actually know about it, it fits very well into the ENT toolbox. Like it makes a lot of things make sense. Like for me, I'll give you a little background about how I got into it. Like, so my office is right below a pediatrician's office. And so when I was initially starting out with my practice, when you start out with practice, like you don't have a lot of patients. You're like just trying to get your name out there and everything, right? So the pediatricians would just send down these babies with difficulty feeding for like phrenotomy, right? Like these babies, I think they have a tongue tie. I may not have even like looked in there, but like they may have a tongue tie, or like maybe I see it like when they open their mouth, right? And I think they have a tongue tie. Like, can you see what's happening? So being traditionally trained, I would clip them, right? Clip them and send them on their way, like no follow-up, right? But well, what happened was I wasn't very busy, so I just like decided, you know what, like let me follow up with them and see how things are going, right? And I was devastated. Like when they actually came back and there was no improvement, I was just like, man, what am I missing, right? Because this is all I knew. Like you just cut it and send them, no stretches, just like, you guys are good. Like it's released, right? Man, that was a sad day when I found out that I was so wrong, right? And the thing is like if you never like see them back, like you never know, right? But so that's what led me down the rabbit hole, right? And you guys were talking about the rabbit hole before. It's deep, man. So I mean, I really appreciate the other ENTs who have put the stuff out there, right? Like Dr. Zaghi, Dr. Gahiri. They really put that stuff out, and it's really accessible. The problem is, are people trying to look for it, right? But it's accessible. So once I determined that I wasn't really doing these patients justice, and you go and you Google, right? Like Google Scholar, like what am I missing, right? Like, and I see these lectures from Dr. Zaghi talking about frenuloplasty. I'm like watching these things to midnight, and I'm like, wow, they just blew my mind, right? And so I went down the rabbit hole, right? So, but that's the problem. Like a lot of ENTs, they don't have time to do that. Like unless they're just starting out, and then sometimes even when they're starting out, like they're so focused on building the practice and like doing this or that other things. But that's the key though, is as long as you have that desire to help patients, and the thing with ENTs is you have all the background, right? You have all the training, all of the anatomic knowledge, like these anatomic structures, you operate around them all the time. And like ENTs love to help patients. Like that's why we do what we do, right? We do surgery because you get immediate benefits a lot of the times. It's really rewarding, right? So the only thing that you have to have then, like what's missing, it's just the open-mindedness, right? So you just have to be open to changing your practice and knowing that like you don't know everything. And that's just for everybody, like nobody knows everything, right? So so in the end, like if you have somebody who's opening to examining their practices and improving on them for the benefit of patient outcomes, like that's what you need. Sometimes you forget that it's like a practice of medicine, right? Not the protocol of medicine, right? So that's what it's about. It's practice, right? Practice makes near perfect.
Very nice. I was going to say, at least ENTs with the tethered oral tissues are way ahead in pediatricians. So I'm surprised that this pediatrician was sending you.
Yeah. Well, the interesting part of that is eventually, so like whenever I see patients, I send the report like same day, next day. So like they would keep getting these reports, right? And so eventually I saw the pediatrician's kids, and of course,
And I usually say this, I feel like it takes a personal experience to get into this rabbit hole. Either you have a child or a grandchild that has some of these issues and you're trying to find a solution, because like you said, most pediatricians and ENTs, you guys are just crazy busy. Even orthodontists, they're just so busy with their practices. I know that over here in Savannah, to just try to get an appointment with any of those three specialties, it takes a long time. So you kind of almost need to have a personal reason for you to try, change your practice, because if everything is working fine, it's tough. But we are so appreciative of you guys for being here and being open to collaboration.
Oh yeah, and the thing is, like, it's just a matter of time before it becomes widespread, right? Because you know that you're doing the right thing, and it's just going to become more and more widespread until it becomes just natural. What's exciting for us is like we're like all making it happen, right? Like everybody here, like everybody on this call, right? This is what you're trying to do, right? Is to make it commonplace, right? So it's exciting. It's pretty cool. So when we're talking about like trying to convince ENTs, right? Like everybody always asks me, like, man, like how do I convince ENTs to like buy into the concept, right?
What do we say exactly? Write it out, the words.
So I think, there's not really one way, but I think, and this is so I want to give like a clinical case for the ENT, right? And this is kind of a case that I present to like trainees when I talk to them about tethered oral tissues, right? Especially like ENT trainees that have learned specific protocols for treating things. So I'm just going to kind of lay it out there. And this is actually a real case. Like this is a real patient. But I'll just kind of lay it out there and I'll kind of like talk through what like a typical ENT trainee or a typical ENT would kind of like think about this, right? So okay, so it's a 3-year-old boy, history of speech delay, chronic otitis media, so chronic ear infections, had bilateral myringotomy of tubes with, so like ear tubes, right? Pressure equalization tubes. and sleep disorder breathing with witness hypopneas and mouth breathing. Okay, so no apneas, but hypopneas and mouth breathing. Patient has 2 to 3 plus tonsils bilaterally. So that's for those who don't know, so that's a size grading out of 4. So 4 being like really big. So 2 to 3, that's like borderline big. Okay. He and the patient is not overweight. Okay. So I asked the ENT trainees, like, okay.
Oh, I like that.
Yeah.
See where
Right.
you're
Yeah,
going with
your
this.
mind is working right now.
Yes.
Like I'm kind of like laying down the seeds, right? But this is a real case, right? This is a real case. So what are they thinking? They're thinking, okay, look at the chronic otitis media. That's treated, right? So you got tubes. The ear stuff is treated. Sleep disorder breathing is not treated, but we're talking about they're having the hypopneas, the mouth breathing. Okay, so mouth breathing. Okay, that's probably like nasal blockage, adenoids, right? The tonsils are 2 to 3 plus. Well, everybody has a different threshold for like pulling the trigger on tonsil removal. But 2 to 3 plus is for me, that's borderline. But for some ENTs, that's an easy like let's remove the tonsils. So sleep disordered breathing is not treated. So let's do the tonsils and adenoids. Okay, so they decide to perform adenotonsillectomy, right? So patient does well after adenotonsillectomy. No complications. You follow up at 1 month just to make sure that everything healed well and everything. They kind of mention, like the snoring's less, but still having mouth breathing, and like the sleep is still restless, but hey, the snoring is better. Like snoring is so much better. So symptoms are still there. So ENTs are like, okay, symptoms are still there. The TNA is done, right? So we already treated the obstruction. So, okay, well, symptoms still there. Let's do a sleep study. All right. So let's do a sleep study. Okay. So sleep study, it shows low AHI. So like less than 1, right? No periodic leg movements, but he moves a lot during sleep. So what do you do now? Like, okay, a lot of ENTs here would be, okay, look at the AHI. The AHI is low, is less than 1. So it's not sleep apnea. Okay. So
you grow out
maybe
of it.
you have to, maybe you have to treat it, right? It's not sleep apnea. So just leave it alone, right? Well, okay, well, so further history taking, reveals, so they kind of leave it alone. So let's focus back on the other stuff that we were talking about, right? So speech delay. So the speech delay persistent after having PE tubes, right? So a lot of ENTs think, okay, well, if you fix the hearing, because there's fluid in there, you put the PE tubes, you get the fluid out, kids can hear better, their speech delay is going to get better. Okay, so but it was persistent despite having the PE tubes placed. Their speech is not getting better. The audiogram that they get after having the tubes is normal. So hearing test is normal. The child has been undergoing speech therapy with some improvement. They've improved their intelligible speech from 20% to 70% of the time, but it seems like they're no longer making progress. They're like hitting a wall. They're just not getting better. So then the question is, like, what do you do now? Like, you've already treated the hearing loss. So, okay, let's get a neurology evaluation, right? Is speech delay, like they can hear, so it must be something wrong with the brain, right? Okay, so that's kind of like the typical ENT analysis of the situation, right? But okay, so here are the holes, though, right? Like, no, okay, well, let's continue the story. Let's continue the story, right? So neurology evaluation for neurologic cause of speech delay shows some signs of ADHD, right? But otherwise normal neurologic and psychosocial development. This is really common, right? Like But okay, so there's not a neurologic issue for the speech delay. Well, what next? Oh man, okay, speech delay. Just send it to speech therapy, right? But they've been in speech therapy for a long time already, like prior to all this, and they're no longer making progress. Well, now what? Right? So that's the problem, right? So now you get stuck and there's nothing to explain anything anymore. Well, obviously we know that there is, right? The speech delay didn't get better after the tubes, so it's not a hearing loss issue. They've done speech therapy and they're just hitting a wall. There's still sleep issues, the restlessness, the mouth breathing still there. Snoring got significantly better, but we know that those are signs of obstruction still, right? Sleep studies, right? So that low AHI, sleep studies are poor at diagnosing like kids, but also at diagnosing like upper airway resistance, right? And so, this is a 3-year-old, like it's going to be difficult to get a good sleep study anyway, right? So, the AHI is not good enough, right? Because there's still symptoms. There's a lot of things in ENT we treat based off of symptoms and not numbers. Why does this have to be one of those things that we got to base on numbers? So, so the big hole is what can explain the speech issue that's not a neurologic cause, and assuming he's getting good quality speech therapy, it makes sense that we look for another mechanical issue, right? Okay, so we've pretty much spelled it out at this point. Right? So we take this one step further. What happens with this patient? Well, we release the tongue tie, myofunctional therapy, release the tongue tie, and actually all these symptoms get better, right? So we talk about. I think we're kind of running low on time. I'm going to skip some things here. So when we talk about, just so that there's time for questions and whatnot, but we talk about collaboration, like things that I kind of look for when I collaborate with other providers from a dental standpoint, like for all the RDHs out there and oral surgeons and dentists, like I'm an ENT, like I know about the terms, but man, you guys got to communicate those symptoms to me, because that, if you tell me that there's gum recession here, that there's diastema, abfraction, like that will, in my mind, it will make me look in those areas. And so when you communicate those things, like that's really like kind of what I need from you, right? Like, I'm not gonna necessarily like be looking at like all the teeth roots, right? So, but specifically, like when we talk about like as part of the care team, management of the maxilla, the mandible, lingual palatal space, huge thing, right? Management of the TMJ. Those are all things that I rely heavily on my dental colleagues and oral surgery colleagues to help me with those things. Part of that is I don't personally have a desire to like, for example, do appliances, right? Like I don't want to learn all that. There's a lot to know. And I know like some ENTs do like appliances, right? But for me, like I'm not treating occlusion. I'm not treating like advanced TMJ stuff. And so if I'm going to do appliances, like I think I'm stepping a little bit out of my depth. And so I'm going to leave that to my dental colleagues. Right? But that's just, I know some ENTs do, but that's just my viewpoint on it. A lot of common ground, dental ENT, and that's where a lot of the collaboration happens, right? Is the floor of the nose is the roof of the mouth, right? So like if you look at this is a real patient of mine here, right? So you show this to an ENT, right? They look at this and they're like, oh man, look at how little space there is in that nose. Look at all that mucus in the sinuses. Let's open up those sinuses. Let's open up that nose, right? But do they look at that tongue? Like, do they look at the space on top of the tongue, like the little air space there? Like before I actually like looked into teledural tissues, I never looked there. I just looked at the sinuses. I look at all that mucosal inflammation in the nose, and who cares about down there, right? But like now, every one of my CT scans, I comment on that if it's there, right? But so that's something from an ENT standpoint, like sometimes you point that out and they're like, I don't understand that. But maybe by not understanding it, if you have someone who's open-minded, they'll ask, and that's how you can convert them or evolve them, right? So a lot of common ground. So I talk about common ground because when I collaborate with other providers, like these are things that we commonly treat like in our separate practices. So like if I work with a dentist, they may be treating the tongue tie, right? So I like to know what they're going to be treating as part of that communication, so I don't step on their toes, right? Because I can offer that too, but like that's kind of just professional courtesy, right? So if you're sending me somebody, but you tell me like, hey, I'm going to do the cranioplasty, like I'm going to leave that alone. In fact, I will support it because I will examine the patient comprehensively and say, yeah, you got a tongue tie. I think you should go down that route, right? But yeah, so a lot of common ground, and that's where we really have to communicate so that we all stay on the same page, right? Communication is collaboration, right? So upper airway goals. So essentially like myofunctional therapy goals, right? So upper airway goals, myofunctional therapy goals. Just kind of give the rest of the myofunctional therapy goals, right? So this is the thing, right? So all of these problems that you're treating with myofunctional therapy, the compensations of the jaw and the neck and things like that. It's funny, a lot of ENTs, they hate that they can't offer stuff for TMJ. Like you just say, NSAIDs, soft diet, like go see a dentist, get a night guard. But like how many patients with TMJ that you look at and they have a lingual restriction, right? Like you can actually offer somebody some information or at least clarity or an explanation of why they're having TMJ. And it may not be the only reason, right? Like, that's why we also have our dental colleagues, right? We send to the dental colleagues because we know that it's not just the tongue sometimes, but a lot of times the tongue is playing a role, right? And for some of these patients, even like realizing that, like it gives them hope that they have some chance of relief, right? And I think that's important too. But yeah, so I have a few other slides here, like kind of like quick and dirty, like evidence slides for collaboration for different fields and whatnot. But I know we're running out of time. I think we have like 5 minutes left or so. So I'll just kind of leave it open for.
Oh my gosh.
I'll leave it open for questions.
Adorable. Oh my goodness, it's so cute. This has been such a wonderful presentation. Thank you so much. I know that people have so many questions. I've been writing over here nonstop. My Lord. First, I would love for you to talk to us a little bit about laryngomalacia.
Okay.
If you don't mind, is that related at all to TOTS, or how does it relate to airway issues? What are the treatment options?
Yeah. So laryngomalacia. So I guess I won't give like a full lecture on it, but just talk quick and dirty, right? So laryngomalacia is collapse of the larynx or the voice box area during inspiration, right? So when you breathe in, so you have your voice box, vocal cords, and then you have the supraglottis, which is like the area above your voice box, and if for SLPs probably know, but maybe other professionals don't know or whatnot. But so when you have laryngomalacia, oftentimes you have excess tissue that's above there. So when you suck air in, you inspire, it sucks the tissue in, and then it causes obstruction. And so you because you decrease that space, you get like a stridor sound, right? Like so inspiratory stridor. Right. And so that's like scary to hear for kids, right? So for babies, it's also like really over diagnosed. Like a lot of times it's actually stridor and not stridor, right? So stridor is more like snoring sounds, right? And not actually like stridor. There's other things you look for, like if it's not just inspiration and it's also expiration, then it could actually be something else and not laryngomalacia. But generally, so laryngomalacia and how it may or may not relate, right? So roundabout wise, so management of laryngomalacia, if it's bad enough, that the excess tissue is bad enough, you got to go in there and just remove it so that it's not collapsing it, right? But there are some things that you can do in the meantime, like controlling reflux, right? If you control reflux, you get less inflammation of that tissue and it can shrink a little bit, and it may be enough to not have as much collapse, right? So in some patients, like a lot of the majority of babies who get laryngomalacia will grow out of it eventually. Like they'll grow out of it, and sometimes you just have to manage the reflux to make sure you keep the inflammation down. So where tethered oral tissues come into play, well, you can get more reflux if you have tethered oral tissues because of the swallow dysfunction or your aerophagia, right? So you're swallowing a lot of air and it's creating a lot of pressure, you get reflux, and that can make laryngomalacia worse, right? Now, I don't know if there's any proof that says that there's an association. Like, I don't think that there's a common causation that causes both, but managing one can kind of help with the other.
Perfect. Thank you so much. Anne, our editor-in-chief, asked, how is radio frequency treatment selected over a turbinate reduction?
Yeah, so it really depends on where the sites of obstruction are, right? So when you do a nasal exam, you look at all those structures, like the turbinate, the septum, the valve. What I find is people who have the best benefit from the radio frequency procedure, a lot of that benefit is going to happen at the valve. A lot of it also happens, like you can treat the turbinate also with the radio frequency, and so you can actually like double treat it, like, and that's typically what you do. So you could just do the turbinate, like if you didn't have collapse of the valve. Then you could just treat the turbinate. There's many different ways to treat the turbinate too. Like you don't have to use radio frequency.
I was checking my nasal valve. Very, very interesting. Is it painful? It's a procedure that's done in the office, radio frequency treatment?
Yeah. So it's in the office. So you numb up everything first. So like the most painful part is actually like the numbing part. Now, I typically will put like a numbing cream in there first that like anesthetizes everything first and then inject. You do have to inject because that fluid helps the radio frequency work. But sometimes once you numb up the surface, like the injections, some people don't really feel the injection. Some people are just more sensitive and like you feel the injection. But once you numb it up, like the actual procedure part where you're applying the energy, you actually don't feel pain.
Perfect. And again, clinically, have you seen palatal expansion result in improved nasal breathing and shrinking of tonsils in children not needing to do a tonsillectomy later?
Loaded question. Loaded question. Yeah. So yes, to part of that at least. So palate expansion have seen improvement in nasal airway. So whenever there's like a younger individual, like kid, whatnot, who's getting nasal, who has some nasal obstruction, and we want to be really conservative because they're young and you don't want to like do too much stuff in the nose. And if I know that they're getting palate expansion, depending on how much of a blockage there is, I'll often say, like, do the palate expansion. And if you're trying to avoid like doing stuff, do the palate expansion first, see what you get, because you may breathe better through the nose enough to where you want to be more conservative. Or you may be able to do something minimally invasive versus something more invasive, as far as like getting the benefit of nasal breathing. I think separating that tonsil question from that, I think I don't think that the act of expanding the palate will shrink the tonsils, right? Like if that's what you're trying to get from that question, like I don't think that in itself. I think if you improve the airway and you improve inflammation that can come from an obstructive airway, you can decrease inflammation. And what is tonsillar tissue? It's immune system tissue that can become inflamed. Mm-hmm. And so if you decrease inflammation, why not? Like it can decrease in size if you have a decrease in inflammation, right? So I'm open to that. I mean, obviously I don't know if there's like studies or anything like this, but I think I'm open to the fact that if you decrease that inflammation, that totally can happen.
I have so many.
Was that enough?
Yes, that was great. We had almost 60 people listening, guys. I know we're out of time and I have so many more questions to ask you, my Lord. We're just gonna have to come back. Anne is over here saying also, can we have Dr. Tran here again? Great information and very comprehensive. Thank you. Thank you, Dr. Tran. Great inspiration for sharing, collaborating for Danelle. Thank you. This is so helpful. Does nasal hygiene with xylitol reduce nasal inflammation?
In general, like saline in itself can decrease inflammation. That's been shown, right? Xylitol, I do have some patients do xylitol, and I would add it to saline, obviously. But you know, there's some stuff out there for like biofilms and things. I have seen patients clinically that do better with xylitol irrigations compared to just nasal saline. What I would say though, if you buy xylitol in bulk, keep it away from your dogs because it's toxic, right? So yeah, just make sure you keep it away from your dogs.
Definitely. I feel like with the amount of questions that I have, we should just schedule maybe another time for you to come back sometime next year.
Yeah.
It's been so wonderful. Thank you so much. And just to let everybody know, we are taking a break for Thanksgiving and we're going to be back. Next Tuesday, we have a naturopath doctor that's going to come talk to us. So don't miss that. And then on Thursday, I don't have the schedule in front of me right now. It's a surprise, but it's going to be a great week. And then December is just packed with so much amazing stuff. A quick shout out to everybody who signed up to Circle Time. We are selecting the participants for Circle Time, and you guys are going to hear from us very, very soon. We're just finishing up a few touches that we have. If you guys have any suggestions, anything you'd like to ask Airway Circle to do, we are here to serve you. If you'd like to hear from a specific speaker, please let us know. Otherwise, we are done with our Tuesday night. We hope everybody has a wonderful Thanksgiving. Thank you so much, Dr. Tran. I hope you have a wonderful time with your family. And
thank you. Happy Thanksgiving.
This was wonderful. Thank you. We appreciate you.
Thanks for having me.
Bye, guys.